Hi, this is Dr. Shaina Rozell. I am a hematologist oncologist with Affiliated Oncology out of Chicago, Illinois. Today, we'll be discussing metastatic breast cancer. This is MD Newsline. In early risk patients, or in early stage patients, how am I determining what patients may have a higher risk of recurrence? Well, I would say, again, there are a number of things. So I look at the patient's clinical characteristics. I look as if they have a larger tumor. I look to see if, for instance, if they have lymph node involvement. I look at those hormone status. So I know those patients who have lower estrogen expressivity, lower progesterone expressivity, they have a higher risk of recurrence than someone who does not, who has a higher estrogen, who has a higher progesterone. Those patients who have a high Ki67, those patients typically have a more aggressive behaving cancer. And so again, those patients have a higher risk of recurrence. Those patients who have lymph node involvement, those patients also have a higher risk of recurrence. And again, along with those clinical features, I use those genomic tests to help me determine what's the patient's higher risk of recurrence. Do they need chemotherapy? Do they need endocrine therapy alone? All in all, based off of the behavior, based off of some of the biology, based off of the clinical characteristics, I can make that determination on which patients are more likely to progress than others. Someone asked, what is my monitoring approach for patients who are early stage hormone negative or hormone positive HER2 negative breast cancer? My approach is not the same as another doctor's approach. And so I want to kind of dispel the myth that there are certain guidelines that you should follow, that everyone has to follow this guideline. They should come in so often. You know your patient, okay? So typically in patients who are within their first year after completing therapy, they'll see me every 3 months. Second year, we may graduate to every 4 months. Once you get to your third year, typically every 6 months, and then you can sometimes go yearly. It really depends on the patient. Some patients like their physician to be a little bit more attentive. Some patients do not want to see their primary provider and say, Dr. Rozell, you're stuck with me, right? So it really depends on the patient that you have and the strategies that you developed. Again, the way I practice is not necessarily the same way as my counterpart. So how do I determine which patients benefit from clinical trials? I would say everyone benefits from a clinical trial. Everyone benefits from a clinical trial. Everyone benefits from a clinical trial. I think we definitely need to do better enrollment for patients, especially in our African American patients. When we do the research, it's not nearly, only about 2% of patients are actually enrolling in clinical trials that are African American. We definitely need to do better. With approval and with enrollment in clinical trials, you have better therapies that are being developed. You have better drugs that are being developed. You have better side effect toxicities that we are learning that vary from different demographics. And so I would again emphasize that every patient benefits from clinical trial enrollment.